want to talk about arthritis, living with arthritis, even reversing arthritis, things that you can do. Maybe a little bit about the incidence. How often does arthritis occur in different types of arthritis? So there's various different types of arthritis. I'm going to focus on degenerative joint disease or osteoarthritis. This is the one that occurs typically with age or injury. Even with obesity, might have increased incidence of arthritis, osteoarthritis. There are many other types of autoimmune. We're going to talk about osteoarthritis today. It's the most common form. And it's estimated that direct medical costs related to osteoarthritis are around $76 billion a year in terms of surgery and physical therapy and everything. And then about that much, again, another 75 billion or so in lost production, maybe missing work or not doing as many activities you did before, retiring early. And real issue is when somebody has arthritis of a single joint, the most common one being the knee, it decreases their activity level, which has a big impact on mortality or longevity. In fact, it's estimated that if you have a single joint arthritis and don't do something to address it, you shorten your lifespan by about 1.8 years if you're normal weight, and if you're overweight or obese, it's more like 3.5 years. And it's mostly due to decreased mobility. So a good example is that as we get older, we need to increase our physical activity, walking, taking walks, strolling, riding bicycles, not decrease it. But if you have limitations because of arthritis, you're more likely to be inactive or less active, which is probably the principal reason your lifespan is shortened. Other studies have shown that arthritis, symptomatic osteoarthritis, is associated with minor or major depression, poor sleep, and weight gain. So these are all considerable considerations right now with the big push towards losing weight with the GLP-1 agonists such as Mounjaro, Wegovy, Zepbound, Ozempic. We're having people that have maybe had less activity because of the weight, and now their weight's down and they have some damage to their joints and they want to get active again. We got to look at what are the options besides surgery. Now, surgery, the common surgery is called an arthroplasty, total joint replacement. And an issue with that is that there's a longevity on these replacements, and the second time around is not so good. So the success rate for a joint replacement is estimated 15 to 20 years before it needs to be replaced. And when you replace the joint the second time, it has a high failure rate, infection, getting loose, having some kind of need for a repeated operation, maybe even incapacitating somebody. So we want to put our surgery replacement off as long as possible. And what can we do in the meantime? Now, do drugs work? No. I mean, there's some evidence that glucosamine chondroitin may give some benefit, collagen may give some benefit, very limited. Non-steroidal anti-inflammatory drugs basically just manage the pain. They don't do anything for the disease itself. Injections that are currently covered by insurance, such as steroids or hyaluronic acid. Let's talk about those. So steroid injections do improve knee symptoms in the short term, but they lead to a sooner onset of needing a knee replacement because the arthritis is there. The steroids decrease the pain and inflammation from it, but also thins out the tissue, and the cartilage gets thinner faster. So the use of steroid actually hastens the time at which you'll be worse. So this is a situation where the drug is actually worse than the disease because it makes it worse faster. So I'm not an advocate of using steroids at all, even though that had been the only option we had, let's say 30 years ago. Then there's something called hyaluronic acid or hyalurons, and these are something it's akin to the fillers that we use in our practice cosmetically, but it's a non-cross-linked, say, lubricant of the joint. When it gets injected in the joint, they usually do 3 treatments. You get some improvement for a few months. Pretty expensive, no long-term effects, and it doesn't actually heal the joint, but it does give some symptomatic relief. So what can we do past that? Well, back in 2017, I wrote a book on stem cells, and I'm not going to talk about stem cells today. That's for another subject. I'm going to talk about platelet-rich plasma and platelet-rich fibrin for osteoarthritis. So platelet-rich plasma and platelet-rich fibrin for osteoarthritis. So briefly, the platelet-rich plasma and fibrin, I'm going to use those together because there's some confusion of what they mean, and I'll give you a brief overview of what the difference is. Not much, but the platelet-rich plasma or platelet-rich fibrin is a blood component. So we draw your blood, typically like a vial or tube, similar that you'd get in your doctor's office for a blood count or a chemistry test. And typically 1 or 2 or 3 or 4 vials are drawn. And it's put in a centrifuge and it's spun. And the top portion, which is the yellow portion, you see a tube of blood spun, there's red on the bottom and kind of yellowish on the top, more clear. We take that yellow, more clear stuff off the top. It's not going to be completely clear. There's platelets in it and white blood cells, but it's like kind of a yellowish, golden, turbid fluid. And that's a platelet-rich plasma or platelet-rich fibrin. And that has healing tissues in it, which is predominantly the platelets, maybe the white blood cells as well. And we want the platelets to be injected into certain tissues to give off growth factors. Now, just a brief discussion about what's platelet-rich plasma and what's platelet-rich fibrin. We can use the terms interchangeably. It's kind of like a generic word. But platelet-rich plasma typically means that the platelets have been more or less paralyzed by an additive or chemical in the tube, most notably something like sodium citrate. And that keeps the platelets from giving off the growth factors and clotting, so it can be handled easier. But then right before we inject it, we may add another additive to reverse the anticoagulant. Therefore, the platelets can go ahead and give off their growth factors. And then that makes platelet-rich plasma into what we call platelet-rich fibrin. It'll actually clot up. That term is not used so much, platelet-rich fibrin, until recent years, because now we have a way to actually draw the blood without additive using special types of tubes and a special type of centrifuge to get liquid platelet-rich fibrin that's stable at room temperature for about 20 minutes and stable in a refrigerator for about 40 minutes. And that's what we're using now, that we're not adding the additives that might impair the ability for the platelets to give off their growth factors. So let's talk about the growth factors associated with PRF, or activated PRP. So number one is platelet-derived growth factor. Platelet-derived growth factor, PDGF, is a factor that causes cells to come into the area. That causes migration of healing cells and tissue cells to where the platelets were at. Let's imagine what platelets were for in the first place. You get a cut on your arm, and it clots up and it heals up, and then there's a scar, and eventually you maybe can't see the scar at all. That's because your platelets recruited cells in the region, skin cells and fibroblasts and myofibroblasts and dermal cells, to come into the area and fix it. So it's a strong healing growth factor. Platelet-derived growth factor causes migration of cells, in this case into the joint, into the knee. Then there's VEGF, vascular endothelial growth factor, that stimulates the growth of circulation. Now, the cartilage has a very low circulation in the region. Now, there's really no circulation inside the cartilage, but this getting to the cartilage, it's got a low vascular bed where the cartilage has to have some nourishment. And that's diminished in arthritis. And the VEGF, which is vascular endothelial growth factor from platelets, aid circulation growth to the area, so it can start feeding the cells that have migrated into the area. So platelet-derived growth factor migrates cells in. VEGF helps nourish those cells. And the last one is TGF beta, transforming growth factor beta, and that causes cells to duplicate. It does other things as well, but and for the case of arthritis, it causes these cells to duplicate. So we want to get cells to migrate in this case, mesenchymal stem cells, your own stem cells. We want to feed them with blood, VEGF, and we want them to grow and turn into new cartilage, TGF beta. So those are the three principal growth factors to help aid the healing of tissue in the knee. Now, stem cells work in a similar fashion, different but similar fashion. We can use stem cells along with PRF or PRP activated. We're going to talk today about PRF and PRP activated because it's very practical, not very expensive, and it's FDA approved and everything. So what do the studies tell us? Well, there's been clinical studies on PRP or PRF for decades. I was the first patient in our clinic that got PRP treatment. So back in 2009 or so, I injured my shoulder and I had a rotator cuff tear. The subscapularis was torn about 70%, and it was a disability. It was hard for me to do surgery and stuff. It hurt when I would throw things, and it limited my mobility. It really impacted my life. And I was scheduled to have a surgery by a orthopedic surgeon that specialized in the shoulder, Dr. Nicholas Schock. He's a friend of mine. He evaluated me and said, we'll do this surgery, shorten your biceps tendon, you'll have a scar along your shoulder, and you'll be functionally normal. Recovery about 6 or 8 weeks. I was like, Now I was responsible for a clinic. I was doing surgery. I didn't want to be out 8 weeks. I had read about stars and athletes getting PRP into their tendons and joints, and it was a new thing at the time. There was kits to make it. So I went and bought the equipment. The first equipment I bought was called the Harvest Technologies kit, one of the early pioneers. And I had my ultrasound technician, who's a vascular technician, learn how to do musculoskeletal ultrasound, at least for the shoulder. And I brought in a friend of mine, another orthopedic doctor, Dr. Jim Kehoe, to inject the shoulder with PRP. Again, this was brand new at the time. And we injected it twice. We did it once, and I had functional improvement pretty much within a couple weeks. And a month later, it felt great. And on ultrasound, when he did the injection, you could see the frayed subscapularis tendon. You see where it was ripped, and he injected right into the tendon. We went to do it again. The tendon had already been healed. We injected anyways, because at the time, the protocol was to do it twice. Really not the case anymore. But we did it a second time. The tendon was already healed. And it's been normal more than a decade later. No pain, no functional disability, no recurrence of injury, and no need for surgery. That wasn't arthritis. That was a rotator cuff injury. And that's what we were first using platelets for, was for repairing tendons and ligaments. And then we learned it also seems to help with arthritis. And this came about comparing the current modalities, which is steroids, steroid shot in the joint, hyaluronic acid or hyaluronins, which is a lubricant in the joint, or PRP, PRP activated PRF, into the joint. What we found was that they all worked for symptoms. The people getting the steroid had rapid relief of pain, but a rapid onset of deterioration of the joint. Okay. Hyaluronic acids, hyaluronins, these lasted, you had to do 3 shots and they got some clinical improvement, lasted a few months and then they sort of fall off. But they got improvement clinically to some degree. And the PRP patients had the most benefit and the most durable benefit, lasting typically 6 months to a year. Now, there was additional studies combining things together, like PRP plus hyaluronic acid, or we'll call it HA, or HA alone or PRP alone, and the combination did slightly better. But the real mainstay was the PRP was leapfrogging ahead of any prior injectable. Again, we're not talking about stem cells. There's some regulation with stem cells that we can still use stem cells, but I'm not talking about comparing it to stem cells. And there have been comparisons of PRP to stem cells, which I'll talk about in a little bit. So the PRP seems to work to improve symptoms pretty consistently, like more than 80% of people have more than a 50% improvement of their joint pain and disability and functional disability with PRP injection. When it first was being done, we were doing it multiple times, 3 times. Now we find that if we use a little bit more platelets, we don't have to do it so often. It might be more like 6 to 9 months. So one study I like to quote was a study looking at severe arthritis. Now there's a grading system for arthritis. It goes to 1 through 4, with 4 being, bone on bone, 3 being almost bone on bone, 2 and 1 being more just arthritis, and 0 being no arthritis. And there's functional scores and pain scores for that as well. And so we look at study done with people that were having 3 and 4. So they were bone on bone arthritis. Most of the studies had been 2s and 3s, more minor arthritis showing improvement. What about more severe arthritis, which we didn't really think would likely work as well? Well, so as we got experience doing more minor arthritis, we started treating people sicker. And we found that they were working just as good, potentially the same. And a large study looking at what they called a survival rate, meaning survival of not needing surgery. So there was a group in the Philippines where they looked at about 300 people that had debilitating arthritis that was scheduled for surgery. And they offered them PRP injections, or PRF in this case injections. They used 2 tubes of blood, made a PRP combination, and injected the knee. And at 2 months, if they did not have a 50% improvement, they said, okay, go ahead and with surgery. And if they had a better than 50%, but less than 80%, they'd say, well, let's do it again at month 6. And if they had more than 80%, they'd said, well, come in when your knee pain comes back. And they followed the patients for 3 years. Long study, but you don't usually have 3-year studies. It's kind of hard to do. What they found at the end of the study is the grade 3 and 4 arthritis, the majority of people, 4 out of 5, did not meet the criteria for surgery anymore. These were people that required surgery that 3 years later, 4 out of 5 of them did not meet the criteria for surgery. That's actually about the same as surgery. So surgery, when people have surgery, about 20% of people still have some functional problem after the surgery. This is 20% of people have problems that they wind up getting surgery or being candidates for surgery. The study didn't assess whether or not they actually had the surgery, so whether they were a candidate. And a candidate would mean that they had, they still had significant symptoms. And this was more advanced arthritis. Since that time, numerous other papers have been done looking at all kinds of grades of arthritis, 1 through 4, and find that it pretty consistently works. You don't need to do multiple treatments up front. And it's looking like you need probably about 3 treatments in a year, maybe 2 treatments in a year, and then maybe once a year after that for maintenance, because you're still having the functional issue that's causing the arthritis in the first place. Maybe your knee's slightly bent, slight valgus or varus deformity. Maybe the running or activities that caused it in the first place are still going on. So you may have to do some maintenance. So we devised a method to kind of mitigate the need for surgery. Again, this is $150 billion a year healthcare waste that we could do if we could save, the country money and save you money and time and effort and surgery, or delay the surgery as long as possible. That'd be a huge, huge home run. So we have a program where you get a subscription model where you get your PRF treatments. Typically we expect, 2 to 3 in the first year, then about 1 a year after that. And if you need more than that, you can get it done, but most people won't. Maybe 1 out of 5 potentially might, because they didn't respond as well, or they might just decide, well, I'm just going to go ahead and have the surgery. This is an option for somebody that wants to get PRF, doesn't want to have the huge costs associated. I've seen costs as much as $1,500 per injection. Shouldn't cost that much. The newer technologies have come way down in price. So what was costing us a small fortune to do PRP in the past is now relatively inexpensive. The technology of getting into the joint, really, really smooth. We use ultrasound. We have ultrasound technicians and mid-levels and doctors trained on using ultrasound, so we can get right in that joint, so we can get precision. we're most experienced with the knees, but we've done pretty much most joints except the spine. And I'll talk a little bit about spine in a later episode, how that can be managed, because that's a little bit more tricky. There's much more complexity to that joint, whereas say the knee joint is this one big pocket that we can get right into, and the PRP spreads all over. The PRP can be augmented with hyaluronic acid, and we're typically thinking the first time you just do the PRF alone, the PRP or PRF alone, get some improvement of your symptoms. Then the second time when you're feeling wanting to have a booster, add the HA at that time. And the reason is that the HA and PRF together delays the onset of relief. Now, even though it gives you more durability and it works synergistically better than either one alone, you don't get as quick of a pain relief with the combination. At least that's what studies are showing us. But I think you should do it anyways, maybe once a year, once every other year, to get that scaffold and that lubricant for the joint. And we're using a cross-linked HA, which has not been prior available in America for the knee joints. And we're using a special sugar alcohol to keep it from breaking down, so it lasts a long time, gives you good long-term relief. So it is a novel way to do this. And again, we're using ultrasound to get in the joint, to get into joints with a lot of precision. We draw your own blood. So the way it works is you get evaluated by one of our providers. Most of our patients have already had a diagnosis of arthritis. Most of our patients have already had a diagnosis of arthritis. So that's the case. You don't necessarily need to bring your records if you know that's what you have. And we're going to go with that. If you're not sure, you might need to be worked up. We potentially could send you for x-ray or refer you to somebody that can make the diagnosis, because this is a treatment for osteoarthritis. It can be used to treat ligament conditions as well, but we want to know, what we're treating so we get it in the right area. So for example, I use my example of having rotator cuff injury. That is different than say shoulder arthritis. Same joint, but when it's a rotator cuff injury, we want to get right into the cuff, right into that particular tendon. Whereas with the shoulder arthritis, we just want to get it in the shoulder joint. So there's some differences. So an x-ray may be needed in some cases, in the MRI with the shoulder to see which ligament is or which tendon is injured. And you come in, we can do it the same day. We draw your blood, and typically be a couple vials of blood, just like getting a blood test done. And the tubes are a special plastic type of tube that is hydrophobic, meaning that the blood doesn't want to stick to the walls. It's less likely to clot. We put in a special centrifuge that goes horizontal, so that way these platelets can slide past the red blood cells a little bit easier. You have way more red blood cells than white or platelet cells. And white blood cells are platelet cells. And some people say platelets aren't cells, they're actually fragments. So they're, for all intents and purposes, a cell, even though they don't have a nucleus. Anyways, they're little balls that can pass through the red blood cells and get to the top. They're lighter, less dense. And the red blood cells fall to the bottom. So that's how we separate them out. Then we put it into a little cooling device to give us a little bit more working time so we can get you prepared. We sterilize the knee or prep the skin. And you can get a little numbing shot. We get the ultrasound and find the area that we're going to inject from. And then the knee is the most common area we treat. We go right above the knee. There's a little space above the patella that has that's contiguous with the joint. And we typically inject there. It's called suprapatellar approach. Shoulders typically done from the back, hips done from the front. Ankles and wrists are done a little bit differently. And these are all done with ultrasound guidance. And after your skin is numbed up, you really don't feel the needle in. There's a little discomfort with it, but it's almost none. The injection gets put into the knee joint and needle's pulled out and you're done. That's it. Now, there might be some tightness feeling in your knee. It might be a little inflamed afterwards, but it's typically not much of anything. And typically you feel better pretty quickly and within a month. And it peaks typically between month 2 and month 6 of improvement. Have been studies showing there's some growth of cartilage again. The joint space is getting better, particularly doing repeated treatments. And it's not necessarily one and done like a knee replacement where you've actually cut the joint out and put in a new metal joint that's going to last 10 or 15 years or 15, 20 years or like a ceramic joint. There's going to be continued wear and tear. So this might be something you plan to do periodically. And we're thinking that the most common pattern seems to be doing it 2 to 3 times in the first year and then about once a year after that. You can even do genetic testing to see which joints are at risk for arthritis. So my genetic tests showed that I would have risk for hip arthritis. I strike that. My genetic test showed I have risk for knee arthritis. The reason hips led in my mind is I have a little hip pain that turns out to be related to something called neuralgia paresthetica. It's a pinched nerve of my pinched lateral femoral cutaneous nerve, which we've treated. But I'm at risk for knee arthritis. So I've done some things over the past 10 years to keep from getting arthritis. So starting out, I did what's called extracorporeal shockwave therapy and photobiomodulation and did x-rays and rechecked the x-rays 6 years later. And there was no degradation of the joint whatsoever, nothing. When I started getting a little bit of discomfort in my knees that would occur after, say, running upstairs or maybe a long bike ride, more than an hour, or like dancing at a Christmas party, my knees would just feel kind of hot the next day, not hurt. And that's really the earliest form of arthritis. It's, really not clinically arthritis yet. The x-ray just shows maybe a little narrowing of the joint space, but no gnarly appearance to the bone. And I've done PRP twice to my knees, once in 20 and once in 23. Now I plan to do it every year just for prevention. And I'm not a symptomatic person to any degree, but I know the telltale signs. I've got the genetic risk for knee arthritis. My mom had both her knees replaced when she was relatively young. She wasn't much older than I am now. She got her knees replaced. And I don't want to get to that point where the knees are looking bad. So there's even like a model where somebody can find out what joints are at risk. And when they start having minor symptoms, get ahead of it. And going back to a personal story, I did my last PRP injection right about a year and a half ago, and my knees have felt great. But we had a Christmas party a couple of weeks ago, recording this in December 24. We had a Christmas party, and I was dancing, and the next day my knees felt kind of hot, and I hadn't had that in about a year and a half. And then the next day, or maybe the next week, I noticed when I ran up the stairs to work, I always take the stairs. We're on the third floor in my main office in Shelby, and I run up the stairs, my knees feel a little hot afterwards. Not bad, but a little bit hot. So I'm scheduling myself for another PRP. That's just a sign that I'm getting a little inflammation. My genetics and my age, this is continue, but doing a shot once a year where I'm getting my blood drawn, separating it out, putting it in a joint, good preventative medicine. So this can go anywhere from preventative medicine to treatment. Now, there's not been big studies on preventative medicine. Probably been no studies on preventive medicine with osteoarthritis because there's no way to do a study like that. You can't follow people long enough. Like in my case, it was a year and a half before I noticed anything again, not even what I would call pain. They just felt kind of hot. So we have to make, that might be a little bit of a leap of faith, and we call evidence-based medicine, where there's plenty of evidence and you have some faith that it's going to help, because I know in my case clinically it did. We're probably going to focus mostly on people that have symptoms, but as the symptoms get more advanced, we used to think it was kind of a long shot and we go right to stem cells or surgery, and now we're realizing based on clinical studies, maybe not. Give it a try. About 4 out of 5 people will still respond with severe arthritis. Again, grade 3 and 4, that's as high as it gets. Bone and bone arthritis is still going to respond, and somebody could choose to do stem cells as an alternative. I would do PRP with it, PRF or PRP with it. And I certainly would give PRF a shot to see how it does to kind of precondition the knees. I said I'd talk about back just a little bit maybe I'll talk about that in a later episode, but the back is difficult because there's so much interconnection between the bones in the lumbar spine or the cervical spine, which are the ones that most commonly become deranged. But people are doing what's called paraspinal injections, where they're doing injections in the area with PRP or stem cells, and they're seeing, because of these properties of the cell migration, cell proliferation, blood vessel proliferation, they're getting some clinical response. So I'm not really keen on that idea yet. I'm still studying it. I'm still looking at what's being done. I know this is being done in clinics in other countries and in America. And I'd say the jury's still out, but that might be some option in the future for people with spinal disease when we can't really get into all the joints quite as easily. It's much more complex and more risky, but can we do something simpler? But the low-hanging fruit is the knees, the hips, the wrists. These are the 95% of arthritis in America. We know that women over 60 have arthritis, symptomatic arthritis, 50% more than men. So men are around 18% have symptomatic arthritis, that are men between 60 and 69, and women is about 35, 36%. So we're about double at 60 to 65, about 50% more overall. If we look at all ages, women have arthritis, about 15%, men about 10%. But as we get older, the rates, go up, and particularly in postmenopausal period. People that are overweight have more arthritis than people of normal weight. People that have been athletes have more arthritis than non-athletic people. However, activity is a slight prevention of arthritis because you're more likely to be fit and not as heavy. And one of the keys are for longevity. If we want to live a healthy life and not be debilitated in our final years, we've got to be fit. And to be fit, we've got to be mobile. And to be mobile, you're only as good as your worst joint. Only as good as your worst joint. So you've got a bad joint, I would get on that and get it resolved. Surgery is no longer the first step. I mean, it was never really the first step. They would do steroid injections and HA, which really were kind of kicking the can down the road. In case of steroids, probably accelerating the time that you have deterioration. So I'd say those are certainly options. They're covered by your insurance. PRP and PRF is not covered by insurance. Stem cells are not covered by insurance. Probably won't be anytime soon. But now this cost has really come down dramatically in terms of the cost of doing these joint injections. And the real take-home message to this is that you have an option. You have an option that is, the insurance companies might say it's experimental and they're not going to cover it, but this is beyond experimental phase. There's been tens of thousands of people in clinical studies, hundreds of thousands of people have been treated, tens of thousands of people in clinical studies treated successfully with arthritis and PRP or PRF, tens of thousands successfully treated. Don't need a whole lot more experiments. What stops insurance companies from covering these things are the lack of big pharma being the contributor to the supposed drug. Well, this comes out of your own blood, so there's no big pharma company involved. So there's nobody pushing for insurance companies to cover it. And this is a standalone procedure. So the drug companies are not going to be there to persuade insurance companies to cover their drug. They do for these drugs called HAs, the hyaluronic acids. They do for steroids, but there's no hero for the PRP. So this is something that will be paid out of pocket. And I think it's a question of what do you love more, your health and your life or your possessions? And if it's your health and your life, then you can pay the nominal cost it costs for doing a PRP or PRF and joint injections to your joint. What determines success? Well, there's probably a lot of factors, but proper patient selection. Somebody has a significant derangement of their knee, is substantially crooked, like somebody has severe bow leg or inverted legs where their knee's kind of cocked in. A little bit more issues with that having mechanical disturbance that's not going to get a lot of results. Could help with pain, but you're probably going to need to do it more often, and it will never probably, go away. But that's, still could be an earlier step before surgery, but that's probably patient selection. Your knee's really crooked and it's bent, not as likely to be a good success. Other limitations are, using the proper PRP. Now there's different kits out there that have different amounts, and this has been debated ad nauseum. It doesn't seem to matter a whole lot. We were using, I went to our lab years ago and took the various kits there and then made it on my own. I could make as much platelets on my own as I could through the various kits, so they're pretty similar. But the big breakthrough in the past few years has been making true PRF without an additive, and that's has a theoretical advantage of not having the anticoagulant and then the procoagulant affecting the release of growth factors from the platelets. Not sure that really matters a lot. It certainly does decomplicate the process, makes it a lot less expensive, a lot easier to do. Is it better? Maybe. Dr. Murin, who wrote several papers on this, over 100, and a couple books on it, he's persuading that this is a better solution. No real studies showing that are in human legs comparing it to the older fashioned one, but he's done different experiments to prove that it likely is better. I think say that's not the biggest issue. The biggest issue is deciding to do it. Very, very low risk. Drawing of blood, low risk. You can get a bruise. Injecting into the joint, very low risk of causing an infection. It's extremely unlikely. It can occur, but it's extremely unlikely. I think the way we were doing it in the past had a little bit more risk because we were handling the stuff a little bit more. Now this is really kind of an almost completely closed system. So very low risk, just like getting an injection of a steroid or HA in your joint, not much risk. And risk of making it worse, none. It's not occurred. So we know that consistently improves. The biggest risk is you do it, you spend the money for it, and you're one of those people, 1 out of 5 people with severe arthritis that did not get more than 50% improvement. That's the inherent risk. And that can happen. So that can happen. You want to go a place like us that guarantees it potentially. So PRP, PRF, almost interchangeable. Most of the time we were activating the PRP to make it PRF, whereas now we're using straight PRF. Stem cells, still an option. Hyaluronic acid, still an option. Steroids, I'd say stop with the steroids for arthritis. It's just a bad idea. That's maybe old school. Does give pain relief, but it's not appropriate in 2024 and 25. PRP is a good first option, first line therapy. I'd try that first. You want to have mobility. And getting back to this longevity thing, I really think now a lot, I'm in my 60s and I think about having a long, healthy life ahead of me. And one of the keys is being fit, being active. So predictors of longevity, there's a lot of them, obviously, genetics and different things, but big predictors are how active are you? The more active you are, the more activity you're capable of, the longer and healthier you will live. So not just long life associated with longer health span is key. So when we talk about longevity, we're really referring to having a long period of time where you're doing just fine. Might be on some medications, but you're able to take care of yourself. You would take walks, you would play with your grandkids. Got 2 grandkids now. I hope to have more in the future and stay active for them. And like I say, my personal experience, I had the shoulder issue, which I treated with PRP back in 2011. I've treated my knees with various therapies because I have genetic risk and I'm not symptomatic of any degree, but I'm going to do a PRF injection in the next month or so because I'm starting to feel something again. It's been a couple of years since a year and a half since I last did it. And this might be something you can just do to kind of maintain your health, just like, exercising and dieting and taking care of yourself and reading and meditating and walking. We take care of our skin. We do skincare, take care of our bodies. We put on deodorant, we brush our teeth, and maybe we got to take care of our joints. There's an option for you now. Doesn't be done that often. I think the first year, 2 or 3 times, and about once a year after that. And good luck. And you're as healthy as your worst joint. So if you have a joint that's bothering you, let's look at options. Thank you.